Okay, so I treat people that come in chronic pain, and I'm always prescribing an ancestral type diet, and I wanted to find out whether there are any specific foods that really can fight inflammation and arthritis and have been studied relative to pain. So, okay.
Oh, yeah.
So that's my new logo on my website, and it talks about all the interactions, environmental interactions and lifestyle behaviors that affect what we do. So nutrition is only a small part of that, but I wanted to see if there are actually any studies. Chronic pain affects a lot of people. It costs a lot, and it's distributed in certain ways. Back pain and headaches are two of the most common. And I treat mostly back pain, neck pain, but I do treat some other weird diseases that cause pain. There's a whole cycle in the chronic pain dilemma: nerve sensitization, central sensitization following trauma, the experience of pain, cognitive processing, depression and anxiety, which often kick in, cortical reorganization with neuroplasticity, avoidance of physical activities and things that we should be doing, disability, muscle spasm, deconditioning, and it goes round and round and round. And so you have to intervene in any way you can. I'm pointing at the wrong thing. Okay. So spinal thalamic tract crosses over, basic neurology, afferent C fibers, tissue trauma, and the important thing about understanding pain processing is that there's ascending and descending pathways. And the way I describe to patients with chronic pain is that the descending pathways basically are a muffler in our neurologic system. And in chronic pain, the muffler turns into an amplifier. And that communicates it very well for most people, because most people are familiar with amplifiers and mufflers. Got to get out of that habit. Pointing at the wrong thing. Am I cognitively impaired? What is it?
It's definitely no you. What's your 23? Yeah.
Okay, so with regard to pain, so this is a projection neuron in the dorsal root ganglion where peripheral nerves enter the spinal cord. There's a lot of processing that goes on here. Inhibition is predominantly occurring here, coming from the central nervous system. And there's all sorts of modulators in the primary afferents and local circuit interneurons, descending inputs, and they're all the usual inflammatory mediators that are involved: substance P, calcitonin, gene-related peptide, vasoactive intestinal peptide. All of those are actors and players. And so I was wondering how much of these can be influenced by specific foods. Okay. Too fast. So acute versus chronic pain. So the hormonal arm versus pain without a purpose. And I deal a lot of the time with pain without a purpose, where there's the neuroplasticity. And that's really tough to treat. The most common cause of chronic pain is inadequately treated or undertreated acute pain. And so in the operating room setting, where I previously spent most of my time, I was very aware of things that would affect post-operative pain and tried to get my colleagues to be interested in those sorts of things, but they just want to get based on the patient with normal blood pressure and heart rate, temperature over the recovery room. Chronic pain alters the peripheral nervous system, the central nervous system, endocrine function, inflammatory systems, and that affects sleep and activity and mood and social interactions, and those go in the same circle of life where everything interacts. So we have to deal with all of these issues, but we're going to talk mostly about food today. So neuroplasticity, just to stay on the topic for a moment, MRI studies show in chronic pain that there is abnormal and functional connectivity. Functional connectivity in terms of metabolic activity in parts of the brain associated with pain, anxiety, depression, and actual autopsy studies in patients with chronic pain, specifically with a problem called allodynia, which means a painful response to a non-painful stimulus, in the 90s elucidated the mechanism of allodynia in a population of patients with something called complex regional pain syndrome, previously called RSD, reflex sympathetic dystrophy. And there were actual connections between lamina 4 and lamina 1 in the spinal cord. And those different lamina mediate sensations of touch and pressure. And the other lamina mediates pain and temperature. So there were actual abnormal connections that were created in these patients with chronic pain that were discovered in autopsy studies that explained this terrible sensation of pain when the breeze went across your skin or your clothing touched your skin or somebody rubbed your arm. That can cause profound pain and disability. Okay, so this is the foot of a 14-year-old girl in Australia. She was a patient of one of my mentors at Stanford. She had CRPS. At that time, it was called RSD, 16 years old. And she had broken her foot, and her fracture didn't heal well. And this is what her foot looked like. And in order to get pain relief, she had to have spinal anesthesia up to a T4 level, at the level of the nipples. So there's something very strange and abnormal going on here. And we know that part of this problem is mediated through the sympathetic nervous system, and that's why sympathetic nerve blocks are frequently used in the treatment of this horrible disease. This clicker is terrible. Okay, so the bad guys supposedly are NGF, TNF, interleukin 1, interleukin 6, PGE2. We all know about those with regard to metabolic disorders, but they're the same players in chronic pain, peripheral nerve sensitization, increased synthesis of neuroexcitatory substances like glutamate, substance P, and that goes into a vicious cycle of increasing peripheral sensitivity, and there's a positive feedback loop, and then there's increased central sensitivity. And so this is the central nervous system and peripheral nervous system gone awry. Is there a specific spot then? Tom, you did it much better than I.
I just clicked it more.
Okay, so.
You jumped one.
Okay, so nerve growth factor, we talked about this. Last year, I was asked by Tommy in an interview, and I didn't know much about the new anti-nerve growth factor monoclonal antibodies, but I read about them. And so nerve growth factor is an alleged player in mediating a lot of chronic pain. And it has been observed in joints to be increased in osteoarthritis, rheumatoid arthritis, circulating levels increased in chronic low back pain, gout, all associated with increased NGF locally and systemically. But the monoclonal antibody drug, which costs $15,000 to $20,000 a year, there's now 3 of them approved for migraine and for other pains, only reduce pain by about 2 points on a scale from 1 to 10. And even though statistically significant difference between those and NSAIDs, I think I'll show some data later. I'll show statistical significance does not equal clinical significance. Oh, jumped ahead. So I read a review article and I created this slide. I was going to delete the slide because after I read the review article and read about 100 other articles, I decided that half of these things have very little data to support them. But these are some of the alleged good guys in supplements and anti-inflammatory foods. And of course, we don't want to forget that things other than food are important. So meditation is something that is always prescribed. And this was an article published in my local newspaper several years ago about post-traumatic stress syndrome and MBSR being effective in at least improving suffering, if not pain. I must have a bad thumb.
I
Okay. So gut microbiome is affected by food, and everything in the body is affected by the gut microbiome. And so we need to talk about that. The HPA axis is involved. The vagus nerve is involved. The gut microbiome definitely has an effect on tight junctions, can increase or decrease leaky gut, which can increase or decrease circulating LPS and other inflammatory factors. And we know that the gut microbiome affects inflammasomes and other epitopes, and that the blood-brain barrier is affected indirectly by all the processes that go on in the gut. And there are certain foods that can affect the blood-brain barrier. We know that the gut microbiome modulates macrophage and dendritic cell activity in the immune system. And we know that the enteric nervous system represents about 80% of the nervous system neurotransmitters in the body. These are all important, so I thought, well, let's look at the gut microbiome, and is there any data on how it affects arthritic and painful conditions? So short-chain fatty acids are produced by the gut microbiome with fiber, and we know that fiber versus sugar is a major issue, and whether we have good bugs or bad bugs. And this has multiple effects on mucus cell production, direct and indirect anti-inflammatory effects. So vagus nerve, two-way street, HPA axis. This is just a repeat of a slide we've seen before. So this was an interesting paper, and although it's talking about mental illness, everything in this paper also applies to chronic pain and systemic inflammation. So this was an interesting discussion where it talked about the progression of the development of the nervous system along in parallel with the gut microbiome. And the gut microbiome, it turns out, affects all of these things: myelination, intestinally, and the role of diet, including breastfeeding versus bottle feeding, et cetera, on the early and later maturation of the gut, the brain, and what they refer to as mentality, which means everything that goes on in your brain. Microbiotic disruption at any stage in this cycle is likely to affect mental health and pain. And there are some neat images of this process. And so these authors, outline different developmental stages from prenatal area to birth to adolescence, and all the things in our environment that affect that diet: breast milk versus bottled milk, school snacks. We all know that snacks are evil no matter what they are, unless they're veggies, fruits, and raw meat. Dark chocolate, right. There are some exceptions. But this was an interesting paradigm talking about the mind as separate from the brain, mental disorders, and the evolution in an individual life of the gut-brain interaction and the microbiota. So, a lot of this discussion is out there in the medical literature, but it seems to be ignored by most practitioners. Again, am I holding it not long enough? Probably. So the microbiome affects the synthesis and secretion of neurotransmitters. It activates the enteric nervous system and primary afferents, and it mediates messages through the vagus nerve and the sympathetic nervous system. The GALT is, of course, as we know, 80% of the immune system in our body is located in the gut, and all of this interacts with inflammation. That's the review article we talked about. So this is a very busy slide, and it's way too complicated. I just can't deal with such complicated pictures. So I thought that, this explains about 50% of the gut-brain interaction. And there's another landline that is not mediated through chemical mediators, which is the vagus nerve. And well, we have to go back to that because I thought that was a very graphic picture illuminating all the negative effects that a deviation from the ancestral lifestyle has in the brain. But getting back to theories, this came from the psychology literature where they were talking about mental illness and the old model versus new model that recognizes stress, diet, what they call psycho and prebiotics, and treatments including fecal transplants, poor diet. Again, this was a great review article, and it just kept pointing to the universality of how food and the gut microbiome affect everything, not just pain. We'll get to the pain part soon, but this reflects the unfortunate bias in all the literature where meat and high-fat foods, of course these high-fat foods which are fried are very bad. We all agree with sugar, food index, antibiotics as being evil. We agree with this being good, although beans and whole grains, no. So these middle four fall out of the ancestral health paradigm. And this just shows even though these folks are very well aware of everything that goes on in the gut, the microbiome, neurotransmitters, neuropeptides, how they're affected by gut bacteria, the connection with the HPA axis. They're aware of all that, but down here, in my opinion, and in the opinion of most of the people around this room, they've got this part wrong. And that's unfortunately what's out there. And so we're going to see that bias reflected in all of the studies that look at diet and rheumatoid arthritis and osteoarthritis specifically. So how does the gut microbiome affect what goes on in your joints, let alone what goes on in your peripheral and central nervous system? I wonder if the battery's low.
Well, let's switch over to mine.
You can try.
See if I have it.
So we all agree that an elimination diet should start with eliminating these sorts of foods. And this is from a review article on rheumatoid arthritis, and relative to the gut microbiome, and there's certain good guys, good players that are lost because of dietary influences. And then the result is increased gut permeability, and the way to alter that is to change diet. And how do they want to change diet? They were in favor of Mediterranean diet, fruits and vegetables, olive oil, low animal fats again, it comes in. I mean, everywhere you look, I could not find a review. There's no ancestral review articles on the effects of diet on arthritis, specifically osteo or rheumatoid arthritis, and on pain. It's just not out there. Nothing's been studied like that. So you're looking at studies on dietary supplements and specific micronutrient deficiencies.
You can just hit the arrow. Yeah.
Okay. So butyrate is one of the good guys, and there are some associational studies that show that butyrate producing gut bugs are deficient in patients with depression, and that in fact some antidepressants actually increase that species of all the species of butyrate producing gut bacteria. And here's an illustration of the enterochromaffin cells and the enteroendocrine cells and the effects of butyrate and other short-chain fatty acids on the whole system, the neuroendocrine system, the processing through the liver, and then entering through the blood-brain barrier, effect on microglial cells, astrocytes, and again, all of this, no matter what review article you read, will go through the same process. And we know that the short-chain fatty acids will improve the mucosal barrier, tighten up tight junctions, modulate inflammation, and alter the recruitment of immune cells. Energy metabolism of short-chain fatty acids will affect so many processes. And here's another illustration of the effects on goblet cells, mucus production, tight junctions from the gut bacteria. And then downstream or upstream effects mediated through vagus nerve and the sympathetic nervous system. So what? Food can alter the microbiome, and so what does that have to do with pain? So Miles Davis wrote a tune named So What? So food affects the microbiome, and we can beat this one to death, and we'll probably hear more and more about that. Butyrate and propionate are probably more effective than acetate in vitro in decreasing inflammatory processes, and this was studied specifically in cells from patients with inflammatory bowel disease. And again, the same story on short-chain fatty acids. So dietary fiber has been associated with lower pain and lower risk for knee osteoarthritis. It's been associated with a lot of things. Two prospective studies showed that higher fiber diets were associated with not only less development and progression of knee osteoarthritis, but pain associated with that. It's also been associated with less pain with functional abdominal pain in children. So cereal fiber was pointed out as being protective, and I'm sure when we hear the talk about food and arthritic pain later, we're going to find out that there's some controversy over that area, because when you look at total fiber and cereal fiber together, I presume that they're going to have the same effects. You may not get the right result. So this again is just a reminder that things other than food affect the gut microbiome. PPIs, acetaminophen, NSAIDs, antihypertensives, they all can affect the gut microbiome in a negative way that can worsen not only metabolic activity, but disease activity with inflammation in joints. So this was an interesting review article on the association of gut dysbiosis with the onset of osteoarthritis, and a depiction of different environmental factors. This was probably the most neutral study I found relative to what's a good food, what's a bad food. So it talks about the genetic and epigenetic, and I guess we have to put this at now 2% and this at 98%. But mediated again through the immune system and the nervous system, and its effects not just on rheumatoid arthritis, osteoarthritis, spondyloarthritis, but also these other areas, autoimmune disease, cancer.
Bob, you said something, when you're talking about medication, one of the classes you mentioned was antihypertensives, which I'm not familiar with their effect.
Well, I didn't go looking deeply into that, but that was cited as a possible disruptor of the microbiome. And our microbiome specialist might be able to comment on that later.
Well, some cause they slow the gut motility.
The gut motility, and then that'll, right. So again here, pretty pictures of this author obviously favored fruits over vegetables. But at least they talked about sugar, fast foods, tobacco, and alcohol, and didn't badmouth red meat. But this is seen repeatedly all throughout the discussion of the microbiome, food, and psychological diseases, cardiovascular diseases, metabolic syndrome, and also with regard to rheumatology literature. So we know that there's good exercise, there's bad exercise, and that also contributes to not just changing.
Wait, what's wrong with lifting boxes?
What's that?
What's wrong with lifting boxes?
Well, he's allegedly lifting them the wrong way.
Okay.
He doesn't have proper lifting technique. I mean, if I tried to do a deadlift and I didn't know what I was doing, I could do a lot of damage. So why is she here? So this gal was the first patient I found on the internet who actually put herself into remission from complex regional pain syndrome using the autoimmune protocol. And this picture was on her blog, and it had all these, and we're going to talk about berries as being really the only food that's been studied in a randomized controlled trial to have an effect on pain and disability in arthritis. I mean, all the other foods and everything else is, I think, BS. So berries, you know, the bottom line, if we all just agreed that berries will help with pain and osteoarthritis, we could go home now, the lecture's done. But it works through several mechanisms, apparently. So this was this obscure study that I found where the microbiome processing berries and pomegranates alters gut inflammation, and it uses ellagic acid, and the result was it can reduce and protect against inflammatory bowel disease, which I thought was fascinating that they were able to hone it down into this process, and that it had an effect on the tight junctions and reduced the gut inflammation in animal models. So this comes from that study, and it talks about gut barrier repair, all as a result of eating berries interacting with your gut microbiome. And, you know, of course, this was in vitro data, but it was a well-conducted study. So berries, fiber, and magnesium are good with regards to osteoarthritis. At least that's what associational studies tell us, and with regard to berries, what actual randomized controlled trials tell us. Now, in the operating room, we use magnesium intravenously to decrease opiate requirements postoperatively, and it works for about 24 hours after one bolus of a gram of magnesium sulfate. So there are mechanistic, physiologic explanations for this, because magnesium competes at the NMDA receptor level, and NMDA is one of the receptors that is involved in what's called acute sensitization with any traumatic event. So low magnesium intake, especially in people with a low fiber diet, is associated with worse pain function and osteoarthritis. But again, that's an associational study. Strawberries and freeze-dried strawberry powders will decrease circulating TNF and lipid peroxides in obese patients with knee osteoarthritis. So does that mean anything? Well, it turns out that it also decreases their pain and improves their functional status. And this was a crossover study where they were given true strawberry freeze-dried product versus just a pink product. And when they got the strawberries, their inflammatory markers decreased and their pain decreased. So the problem is that if you look at interleukin 6, interleukin 1 beta, matrix metalloprotein enzymes were all significantly changed in these patients just within 2 weeks. But no, I'm sorry, after a 2-week washout period, that was reversed. It was after 12 weeks. But it was statistically significant, but was it clinically significant? I was very disappointed. VAS is visual analog pain score. So that wasn't statistically significant, but all these other measures, which were composite measures based on a questionnaire relative to constant pain, intermittent pain, and total pain, decreased, you know, a reasonable degree. On a scale from 1 to 100, they went from 31 down to 13. And I'm sorry, I don't have the individual data. But I guess if I use that statistical program with the standard deviation, I could generate. But so this is clinically significant. If you can get somebody to drop 20 points on a scale from 1 to 100, which is 2 points on a scale from 1 to 10, which is the best NSAIDs do, anti-nerve growth factor antibodies, anything that's been studied other than opiates for acute pain. All those studies show about 2-point drop. Spinal fusion and chronic low back pain, 2-point drop. It's like this recurring number that you see in the pain literature. Just about whatever we throw at it, you'll drop it by 2 points on average, which means that there are some that don't get any pain relief and some that get a lot of. So this is an anti-nerve growth factor monoclonal antibody. This is data taken from that study on osteoarthritis of the knee and the hip. And pain levels dropped with the drug and with placebo. Is that a huge difference in the WOMAC pain score and in the functional impairment score? It's no better than an NSAID, and at a cost of $15,000 to $20,000 a year. And at God knows what side effects, because the study populations have been very small, and we'll have to wait for the post-marketing reports, which are always suppressed anyway. So this is from the same or a similar study, real p-values, and versus naproxen, they alleged it's better than NSAIDs. Well, how much better than NSAIDs? Naproxen minus 1.66, and these are the various doses of the anti-TNF antibody. Statistically significant, yes. Clinically significant, I would suggest no, just as an aside. Okay, so blueberries, 40 grams freeze-dried. The strawberry study was 50 grams freeze-dried, and they all had about the same results. So are blueberries better than strawberries? But anyway, they improved gait performance, inflammatory markers, in symptoms. No changes in the disease progression as based on X-ray, but these short-term studies would never show that anyway because it's not a long enough time period. But you know, these guys used an equivalent of a pound of blueberries per day, and the strawberries was the same thing. It was the equivalent of a pound of strawberries per day. And it did produce clinical response. Now, mind you, those folks probably still stayed on the standard American diet. So it's in an environment of incredible inflammatory epigenetic processes going on, but yet the equivalent of a pound of strawberries or blueberries was able to change pain to a clinically significant degree. And I thought, wow, what would have happened if they had adopted an ancestral diet and had a pound of blueberries and freeze-dried? You know, of course, my bias says they would have done much better. So what's in a berry? And we've got strawberries and blueberries, and there are all these alleged great anti-inflammatory mediators that have probably worked through hormesis, because we know that the antioxidants in fruits and vegetables, for them to work as a direct antioxidant biologic effect in your body would require you to consume like 20 pounds of broccoli a day or some ridiculous amount. So these are some of the alleged potential mediators of reducing inflammation through a hormetic effect, most likely. So OPCs. Now, Tommy told me a couple of years ago that especially bilberries, but blueberries and the OPCs and those are reported to improve the blood-brain barrier. So, but I don't know the data on that.
The direct MMP inhibitors, so you have particularly MMP9. So that's why I always gave blueberries to the multiple sclerosis patients.
Right.
So because they have a, I don't think it's necessarily a hormetic effect. I think it's
A direct
inhibition of the enzymes that are upregulated.
So the blueberries and strawberries and osteoarthritis are good. And we can conjecture all of the possible beneficial nutrients and micronutrients that are concentrated in those things, but that's all speculation. So influence of diet on the gut microbiome. An interesting review article on studies of fiber and resistant starch on all these species, and most people recognize what we generally consider as good guys, bad guys, good guys. And, you know, the carnivores don't think that the fiber is very important, but to the degree that fiber feeds bacteria to produce short-chain fatty acids, and to the degree that those have a real effect other than theoretical effects, we just don't know, except that we know that there are associational studies in which high fiber diets seem to be associated with less development and a less symptomatic manifestation in some arthritic conditions. Ethanol, you know, we don't need to talk too much about this, but there is data on ethanol and its effects on the microbiome and on gut inflammation directly and on systemic inflammation, intestinal permeability, bacterial dysbiosis, bacterial overgrowth, all have been studied in folks with ethanol problems. And some of the mechanisms have been worked out. DNA adducts, reactive oxygen species, and we know mucosal ulcerations, erosions, loss of the epithelium, all associated with excessive use of alcohol. What's excessive? It depends on how much you or I personally take. We all think that excessive alcohol is more than what we consume. And if we consume zero, then we presume that anything more than zero is excess. So, we'll never solve that problem, but this shows how there's trans epithelial and changes in permeability, neuroinflammation, fibrosis in the liver, vicious cycle. So increased consumption of alcohol is associated with disease severity in rheumatoid arthritis. And prospective observational studies, and again, this is all associational data. These folks created a flavone derivative. You know, somebody's always looking to make a drug, and so they created a flavone rather than rely on what occurs in nature. They studied one that they produced in the lab and found that it had a direct analgesic effect in nociceptive pain, not chronic neuropathic pain, but nociceptive pain in mouse models. Now, it's just about the only data that I can find in studies that show, in all these studies were done in rodent models where there's an antiseptic response to some nutrient or micronutrient. So obesity and chronic pain, probably 50% of the patients in my pain clinic are obese. Many of them morbidly obese. And we know that there is an association with depression, less physical activity, and all these feedback on each other. There's obesity-related pain in multiple studies: fibromyalgia, osteoarthritis, rheumatoid arthritis, low back pain. And the data on low back pain is pretty clear. If somebody smokes or they're obese, if they don't lose weight or quit smoking or both, they're not going to get better. We all know that adipose tissue is an endocrine organ, and it's involved in the regulation of inflammation. And so changes in lifestyle can improve both obesity and chronic pain conditions, but try to get patients to do that. If anybody finds how to change human behavior, and Chris Kresser claims that he has some answers, but I don't know. He has a very a much more motivated patient population than I do. So visceral adipose cells, macrophages produce cytokines, chemokines, all of which contribute to central and peripheral sensitization. Interleukin-6 is associated with hyperalgesia, which means a more profound painful response to a painful stimulus, fatigue and depression in multiple clinical situations, including chronic pain. One thing that I learned in reading through this literature is that obesity is associated with 50% of the cells in adipose tissue in obese patients are macrophages. And in a lean person, 10%. And that's human biopsies. I had never read that before. Was anybody familiar with that data? But that sort of jumped out to me. I thought that has to have some kind of effect, not just on the processing of pain, but on the whole systemic inflammatory response. So the relationship between fiber and markers of inflammation. Again, associational data and biomarkers rather than clinical endpoints, but interesting studies that show the more fiber you eat, on average, the lower the CRP and other inflammatory markers.
Dietary fiber, not nutrition.
Dietary fibers, yeah. Short chain fatty acids, the not clinical endpoints, but biomarkers, again, decrease all these inflammatory markers and increase the production of the anti-inflammatory cytokines. And it also inhibits downstream the LPS-induced NFK beta activation. So anxiety and depression, surprisingly or unsurprisingly, are much more prevalent among people with arthritis. And so the rheumatology literature talks about, we should be addressing these patients' anxiety and their depression, but it doesn't say, exactly how should we do that. So these docs, when Emily Deans gave her talk with Drew Ramsey at the American Psychiatry Association meeting several years ago, that was the last time we saw Emily Deans at these meetings. But Drew Ramsey is pretty much a Mediterranean, almost vegetarian kind of guy. But they did this study where they looked at all the nutrients that they believed had an effect on depression and analyzed foods to see what foods were the best foods to have all those antidepressant micronutrients in them. And I thought, wow, that's a pretty cool concept. Let's see where it goes. And so they came up with 12 antidepressant nutrients. And those are, the usual suspects. And the highest scores among the animal sources were, lo and behold, bivalves, oysters, mussels, seafoods, and organ meats. Imagine that. And the highest scoring foods among the plants were leafy greens, peppers, cruciferous vegetables. So that sounds pretty ancestral to me. And I sent this review article to the chief medical officer, the chief nursing officer, and the CEO of a psychiatric hospital where a family member was. And that psychiatric hospital, this family member was admitted with an acute depressive episode. The only access to the outside and to exercise that this family member had was twice a day. She could walk down the stairs to go out with the smoking group for 15 minutes. And the only green leafy vegetable that was available was iceberg lettuce. The one cruciferous vegetable was broccoli. And pretty much they were fed rice and potatoes and bread and delicatessen meat. And, you could get eggs. I mean, it was an amazing experience just dealing with that over the phone.
Margarine on the broccoli, I'm sure.
Possibly,
Right, and the heritage of those eggs.
Right, they were probably powdered eggs. So how does
What response?
Zero. I wrote about it on my blog. There was no response. And I sent them several papers, not just that paper. And I said, really? This is how you treat major depressive episode. So, okay, what's the diagnosis? Right, swan neck deformity, right? So, lo and behold, observational association studies show that the gut microbiome is different in patients with RA when you compare them to healthy people, when you compare them with fibromyalgia. Fibromyalgia microbiome is abnormal, but it's abnormal in a way that's different from rheumatoid arthritis. And we've got no idea why. It's all observational studies, but something's going on there. And the good guys that we believe are good guys, you know, are deficient, and the bad guys that we understand to generally be bad guys are elevated. But interestingly, in rheumatoid arthritis, treatment with biological agents, you know, the monoclonal antibodies alters the gut microbiome. Whether it does it in a good way or a bad way was unclear to me because I saw data in both directions. So, of course, association does not equal causation. We've got to address all of these other factors. And the setting of these other factors will probably affect what happens when you alter or attempt to alter the gut microbiome. If you try to alter it just with food and all of these other things are not being addressed, you're not going to get any real results. So this was a review article, biased again, in rheumatoid arthritis, where it talked about the gut microbiome, and it referred to the literature on dietary interventions. And there have been a few in rheumatoid arthritis, and we're going to talk about those. Vegan diet, elemental diet, elimination diets, which I wasn't aware existed, but there are a few in the literature on RA, and of course, Mediterranean diet. And so these folks never heard of the ancestral diet. And this is another depiction of how food and the microbiome affect synovitis and arthritis. So before we go to those dietary studies, interventions with fish oil and rheumatoid arthritis are probably two things that are linked in the literature. There have been many, many studies on fish oil, and more than 90% of them, despite not changing anything else in the diet, show positive effects, pain reduction and decreased disease activity. And the doses are very variable, but there's obviously many mechanisms that EPA and DHA have effects on inflammation through the arachidonic acid metabolism system. So not only are they directly and indirectly anti-inflammatory, but they're inflammation resolving. We know about resolvins. So this is one trial. It was a huge dose, 5.5 grams of EPA plus DHA. That's not 5.5 grams of fish oil. So 139 patients with recent onset of rheumatoid arthritis, and they were naive to disease-modifying agents. So 1 year, the high-dose group had 2 times the remission rate and 75% decrease in the failure rate for disease-modifying agents. They did not control the N6, N3 ratio, and they did not measure the omega-3 index. None of these studies do, which just boggles my mind. What if they have gotten rid of vegetable oils and sugar, let alone follow the AIP? But nevertheless, just giving fish oil had a clinically significant effect. This surprised me because they didn't change anything else. So protectins and resolvins, EPA through lipoxygenase into the E-series resolvins, DHA into the D-series protectins and resolvins, diminished leukocyte chemotaxis, platelet activation, induces apoptosis of activated T cells, and phagocytosis of apoptic neutrophils and macrophages. Many mechanisms that have been elucidated in vitro that probably have meaningful results in vivo. These are also molecular or biological mechanisms associated with omega-3s, immunoregulating phenotype versus phenotype here, affecting almost every element of the immune system that's been studied, M2 macrophages, regulatory T cells, and the SIRT system and AMPK, of course, have been studied, and all of these mechanisms are involved. Epidemiology, rural Japanese despite increased genetic risk, have a lower RA risk. Inuits, lower RA risk compared to Danes. In the US, if you eat fish once a week, you've got reduced risk. If you eat it twice a week, you've got more reduced risk. Just eating fish once or twice a week has an associational, pretty significant change in risk, much more than the risk changes in SNPs, right? So in RA, there's been a total of 20 clinical studies with omega-3s, and 9 have been studied in lupus, and 6 of those exhibited significant improvement in one or more clinical outcomes for the lupus studies. 16 of the RA studies exhibited significant clinical improvement in the disease outcomes, and 4 clinical trials in osteoarthritis, 3 of which showed significant improvements. And again, this is just giving a supplement, one single supplement, not giving any other dietary advice or lifestyle interventional changes. So, you know, we talk about, well, don't give omega-3 supplements, change the diet. There's room here for one specific supplement in these clinical situations, because it's a lot easier to get somebody to take a few fish oil capsules than it is to alter their diet completely. Okay, so here's the vegetarian and the vegan study, which is referred to over and over and over again in these review articles. So they fasted for 1 week. It was a water fast, water, coffee, tea. And they were gluten-free vegan for 3.5 months. And then they changed over to lacto-vegetarian. And I have no idea why they did this. You know, the fasting followed by vegan, then lacto-vegetarian. But if you had just read the abstract, you wouldn't know that they reintroduced dairy and eggs after a period of time. And if the patient had a negative response, they removed it again. So there's an elimination diet to this that overlaps with the AIP, because they eliminate gluten, dairy, and egg, okay, which is part of the AIP. And they prescribe lots of fiber. So I could see how they would get some results. So there, 12 out of 27 patients were responders in the vegetarian arm, and 2 out of 16 improved in the omnivore arm. So therefore, you should, you know, if you've got rheumatoid arthritis, you should be vegetarian, right? But as a group, the vegetarian arm responded, but when you look at it, there were only 12 responders. So, and this was an interesting statement. 1 year after the patients completed the trial, they were re-examined. Compared with the baseline, the improvements measured was significantly greater in the vegetarians who previously benefited. Duh. I mean, if you responded, you responded. And I couldn't understand the point that they were trying to make, but this is an example of some of the silly things that people say when they're summarizing their studies. Interestingly, for the carnivores in the audience, loss of muscle mass noted in the vegan phase, improved when dairy was reintroduced. Surprise, surprise. But at least they made that observation. So there is some association between Proteus and rheumatoid arthritis, and there's a 6th amino acid sequence epitome that closely resembles an epitome involved with the immune system. And antibodies against this epitome are increased in rheumatoid arthritis more than in ankylosing spondylitis and healthy controls. So there's some suggestion that there's an association in RA. So this was a elimination diet study and a study in RA patients to see if they had antibodies to specific foods. I didn't know this study existed in the literature until I started reading through this for this talk. So serum antibodies to gluten and casein were increased in RA. Hooray, you know, there's some supportive information for the autoimmune protocol. So IgM, IgA activity significantly increased as a group in rheumatoid arthritis patients against various foods. And in the intestinal fluid, the antibodies were more strongly associated with rheumatoid arthritis than the circulating antibodies. I'm not sure what the meaning of that is, except that we know that the immune system is affected by food and that people specifically can react to things such as casein and gluten, which are considered to be some of the primary suspects in the elimination diet for the autoimmune protocol. So this was a so-called an experimental study, controlled to a degree in the Mediterranean diet as an intervention in rheumatoid arthritis. So what they did was for 3 weeks, they fed these people a Mediterranean diet, but it was only 2 out of the 3 meals a day. And then they sent them on their way and said, this is a Mediterranean diet, this is how you should eat. And 12 weeks later, they did some measurements, and they found that the Mediterranean diet compared to control had decreased disease activity. Ergo, all the review studies say, well, you should either go Mediterranean or vegan or vegetarian. So supplements in RA, there have been many supplements studied, and you just don't know what to do with some of this data. Here was a study done with multiple antioxidants. They didn't measure, in most of these studies, they didn't look for deficiencies. They didn't look for the starting point. They just said, we're going to give these people this mixed bag of antioxidants and see what the results were. So lo and behold, the antioxidants decreased the antioxidant levels as measured, but it also decreased disease activity in rheumatoid arthritis, which was interesting because, again, they didn't alter diet, they didn't alter anything in lifestyle, they just gave some antioxidants, and there was measurable change in disease activity. Whether it was clinically significant is debatable, but no change in disease activity with probiotics in a few studies. So fasting followed by vegetarian. There was another fasting study followed by a vegetarian diet, and it showed some changes in disease activity, clinically significant, long-term effect. So the patients weren't obligated to stay vegetarian, but they followed the patients who had been vegetarian for a prolonged period of time and then didn't know what they were doing after that, but there were still changes in disease activity. Now you could posit that maybe they increased their fiber, improved their microbiome, had more short-chain fatty acids floating around, had some other improvements in micronutrients, but that's all speculation. So zinc and magnesium for pain. I've already talked about magnesium for acute pain in the surgical setting. Zinc deficiencies and magnesium deficiencies are associated with increased pain in various human arthritis association studies. We know that magnesium intra and post-op decreases analgesic requirements. And we know that there are biological explanations for why zinc and magnesium are important relative to inflammation and for pain processing. So this just talks about zinc excess, zinc deficiency. Don't give too much. Zinc is a cofactor in so many processes, and we know that in the depression literature, zinc supplementation can produce clinical results. So some proposed mechanisms for why antioxidants, this comes from the antioxidant supplement studies, why it could have an effect on pain, cartilage damage, oxidative stress. So there have been a few supplements that have been studied in osteoarthritis. The most studied is curcumin and some derivative of avocado, soybean. The Cochrane review said curcumin and avocado, soybean, unsuppressed unsupportable are the best studied and have the best data and are the only thing you could recommend clinically. I disagree with that based on some of the other studies that I read about Boswellia and pycnogenol. And I take both pycnogenol and curcumin for my arthritis pain. So 5 lox-in, 5 randomized controlled trials, 2 high quality, 100 milligrams a day, improved pain compared to placebo in osteoarthritis. Curcumin, there have been so many studies and so many review articles written about curcumin. And the authors in one review article on curcumin said that even though you need to package it to increase bioavailability, there have been studies with 6 grams a day of unaltered curcumin that have shown beneficial results, relative to pain and function in osteoarthritis specifically. So pycnogenol was one that I hadn't heard about until about 2 years ago, and I started researching and reviewing. And it's 150 milligrams a day, 50 TID, and it's about equally effective as ibuprofen at high doses, 600 to 800 milligrams 3 times per day, as is curcumin. So both of them have been compared to NSAIDs and found to be equally effective after 3 months.
Pycnogenol is also a good anticoagulant.
What's that?
Pycnogenol is how you say it. It's also a good anticoagulant.
Okay. So the results are always, it spares non-steroidal inflammatory drug use. Everybody decreased their doses of NSAIDs that were allowed to take NSAIDs while they continued in these studies. So let's see. This is a curcumin versus ibuprofen, and you can see that they're practically the same in different scores. WOMAC is a composite score of pain or function. And they all showed clinically significant as well as statistically significant changes. But again, on a scale from 1 to 10, most of the time you're seeing a 2-point reduction, but here's the standard deviation. This was a study, another study on a specific curcumin supplement that came out of either Finland or one of the Scandinavian countries. And I chose this data because it was the only study I could find that looked at more than just knee osteoarthritis. Knee osteoarthritis seems to be the thing most studied for nutrition, for dietary supplements. But this looked at over 1,000 patients, and it was a mix: spine pain, shoulder pain, knee pain, hand pain, hip pain, neck pain. And they all seemed to have a response to curcumin. And this was I forget whether it was a nanoparticle or a phospholipid, but somehow they enhanced bioavailability. And so these results are the strongest I've seen, going from an average of 7 to 3 points. That's a 4-point change. That's twice the usual 2-point change that you see in most of these studies. And it all occurred most of it occurred within 6 weeks, which was the earliest also. Most of the studies look out at 3 months for supplements and changes in function and pain and osteoarthritis or rheumatoid arthritis. And this has to do with mobility. Again, a reasonable clinical response in all of the categories. So curcumin, 13 out of 14 randomized controlled studies showed decreased pain and improved function. 2 studies looked at inflammatory markers only, and they were reduced. Absorption enhancement is advisable, but not necessary if you take a high enough dose, and presumably if you take it with a fatty meal. And curcumin's been studied in so many disease processes. I mean, this was a curcumin review article. I mean, it's just amazing. A lot of these are in vitro studies, but there are ongoing studies in the oncology literature and the rheumatology literature. And the only side effect that I could find outside of some antiplatelet function was enhanced gallbladder mild contraction, which means if you've got some gallstones, you can precipitate a gallbladder attack if you take curcumin. So I always tell patients, you know, if you've got gallstones, you know, you could get a gallbladder attack taking the supplement, but other than that, it's pretty benign. So blueberries and strawberries are good. Bilberries are probably better. That's what Tommy says. EPA and DHA. Supplementation without changing anything else has been found to be effective in rheumatoid arthritis in a lot of studies, in osteoarthritis in a few studies. These have been studied well in osteoarthritis as supplements, and they all are as effective as NSAIDs. The microbiome affects everything you can imagine in your body, and we're going to hear more about that later. We can argue forever about what's the ideal microbiome diet, and there probably isn't one. It depends on context, and if you don't address things like sunshine, exercise, environmental toxins, stress, and social support, you're not going to get results. Pain and depression literature supports magnesium and zinc, and we don't know whether that's because so many people out there are deficient or whether because there's an actual pharmacologic effect above and beyond normal levels, whatever normal levels might be. And that there's a cycle of pain, depression, sleep disturbance, sedentary behavior, isolation, social isolation that goes round and round in a circle that needs to be addressed in chronic pain. So eat antidepressant foods, get sunshine, focus on stage 4 restorative sleep. We all know the things you need to do for that. Love and laugh, exercise outdoors, walk in the bare feet, ground yourself. Do yoga, meditation, whatever it is that floats your boat. Filter your water, eat organic, and pasture food. For autoimmune disease, of course, consider the autoimmune protocol, which includes more than just dietary changes. And I think everybody should have the omega-3 index checked. I don't know how many people agree with that, but I think it's one of the best biomarkers. There's a cheap home skin prick test kit that will give you good information and that you can track your response if you make some dietary changes to see how responsive you are to those dietary changes. We all know we should check for nutritional deficiencies, worry about environmental toxins, check for heavy metals. Tell patients that supplements are a waste of time if they're not changing everything else. And certainly the Mediterranean diet is better than the SAD, but the ancestral diet is hopefully better, although we haven't proven anything other than that blueberries and strawberries can reduce pain. Curcumin can reduce pain, some supplements can reduce pain, and omega-3s are important. After reviewing as much of the nutritional literature that I could, that's all I could come up with. I'm sorry, there's no. So, oh, and we didn't talk about sauna plus. Far infrared sauna is my bias, but Finnish sauna has good data on cardiovascular disease. And everyone would agree that the first step in an elimination diet is to get rid of that stuff to avoid that and achieve optimal health. Thank you. Yes.
I just wanted to comment that over the past year, I started checking RBC and plasma zinc routinely in a lot of patients, not just in everybody, but in